Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. And welcome to Pediatric Cardiology webinar. Many thanks to everyone who is making the time to join us today. We have a real pleasure and privilege to moderate this webinar with the great pediatric cardiology team from Sudan. And the theme of this webinar, I think from the beginning, is mainly with regard to how to establish service in developing country like Sudan. But first of all, let me to say that I would like to congratulate Dr. Sulaf and Professor Abdul Munaim and their team for the great job they have done in Sudan. They have done amazing job. The burden of the rheumatic heart disease in Sudan had significantly reduced. But I think the question is still there. I think there's a bridge gap, and I think the question exactly how to fill this gap. I think that the main reason today we're hosting this webinar with regard how to improve pediatric and congenital heart disease and cardiac surgery in Sudan. To start this webinar today, I would like to welcome Professor Sulafa Khalid to start to introduce the first session speaker, Professor Abdul Munaim. Professor Sulafa, over to you.
Yes, indeed. Thank you very much, Dr. Abdul Azim. It's a great advantage to have you with us and to throw light on the service of this complex specialty in Sudan. I have all the pleasure to welcome my professor and senior colleague, Dr. Professor Abdul Munaim Assid. Professor Abdul Munaim, as many of you know, established the service in Sudan long time ago in 1975, and that was a pioneering work to do at that time where the pediatric cardiology was just maybe not yet born completely. So, and he had also the honor to establish this service in the western region of Saudi Arabia in about 1986 or so. And we have the pleasure to have him back in Sudan for the last few years. I would like to welcome him and ask him to go ahead and speak his presentation today about congenital heart disease. Professor Abdul Munaim.
Professor, Prof, do you mind unmute your mic? Yeah? Sorry, we can't hear you, Prof. Just unmute your mic. Your microphone is mute. Okay, yeah, that's good.
Good. Can you hear me now?
Yes, we can hear you, yes.
Yes.
Assalamu alaikum wa rahmatullah.
Wa alaikum assalam.
Thank you very much, Prof. Salafa and Dr. Abdul Azim. And I'm very honored to join you on this Zoom meeting. And very much looking forward to future in-person meetings once we have the COVID-19 behind us. In fact, the story of congenital cardiology in Sudan is a bit pleasant and a bit unpleasant to talk about. We were amongst the first to start this subspecialty in the region, and it was an early and good start. But to the sarcasm of fate, we are now in a relatively low position when compared to many countries, especially in the Gulf region around us. So I must start by saying that the subspecialty of congenital cardiology has always been nurtured by two closely related specialties, and that's cardiac surgery and adult cardiology. In Sudan, cardiac surgery was started in Khartoum Civil Hospital, which is now Khartoum Teaching Hospital. And that was back in the late 50s, again, an early start. And the honor for that goes to a British surgeon, Mr. John Jakes, who joined the Faculty of Medicine, University of Khartoum, as a young surgeon specialized in cardiac surgery. So that was an important person to know about. Then in 1962, again, a relatively early age, the first adult cardiac unit was established in Al-Sha'bi Teaching Hospital. I think these two basic steps should always be borne in mind when we are discussing the sort of rise of pediatric cardiology in Sudan. As I said, Dr. John Jakes was one of the first, in fact, he was the first surgeon to start cardiac surgery in Sudan, but he was very much influenced by what was going on. John Lewis from Minnesota successfully introduced hypothermic circulatory arrest to the whole world when he closed an ASD in a female child. And that was in 1952. As in 1959, Dr. Jakes used the same technique.
Okay, I'm sorry. I think we just lost Professor Abdelmonem, I think, at the moment. Hopefully he will join us shortly. I mean, meanwhile, I think Professor Abdelmonem, Prof, can you hear me now? Prof, just unmute your mic again, please.
Can you hear me?
Yes, we can hear you, Prof, yes.
Yes, okay. So 7 years after the technique was actually introduced in Minnesota, it was being practiced by Mr. Jakes in Khartoum Civil Hospital. Now, I think the name of Mr. Jakes should be in the memory of every cardiologist, not only because of his pioneering work, surgery, but also in cardiac surgery, but also because he unfortunately died very suddenly in England of subarachnoid hemorrhage shortly after he went back from Sudan to England. So, slide. Throughout the 50s and the early 60s, there was only a single surgical complex in Khartoum Civil Hospital, and rheumatic heart disease was the dominant practice in cardiology. Compiling the first list of patients with rheumatic heart disease in Sudan in the early 60s was again done by Mr. Jakes and Dr. Abdul Halim Muhammad. And they published this in 1961 in the British Heart Journal. You can see the reference at the bottom of the page. A third name whom we should mention among the founders of cardiology in Sudan is that of Mr. Ahmed Abdelaziz, who was the senior surgeon at that time. So all these were primordial stages for creating a medical and surgical cardiac subspecialty, perhaps one of the first to be created in Sudan. Other specialties followed. When I returned to Sudan back from England, where I used to work at the Brompton Hospital, also at the USA, I immediately started looking after hundreds of children with rheumatic and congenital heart disease, both as inpatients and outpatients, thus forming the nucleus for pediatric cardiology service for the first time in Sudan. In 1975, and that's 13 years after the inauguration of the first adult cardiac unit at Ashab Teaching Hospital, the first dedicated pediatric cardiology clinic was also established. The flow of patients was really amazing from the start. Initially, they came from Khartoum area, but eventually from all over the Sudan. And in the decade that followed, over 3,000 patients were recorded or registered in that clinic. Undergraduate teaching and postgraduate activities in pediatric cardiology received a huge boost by the abundance of rheumatic and congenital heart cases that were seen in that clinic. And also scientific research was published and presented at that meeting from that clinic. We enjoyed a number of international visitors, including Dr. Elliot Scheinborn and Michael Joseph from the Royal Brompton Hospital, and also Dr. Leonard Dreyfus, the president of the American College of Cardiology, who was visiting heart disease patients in the clinic. Now, an important milestone in the history of cardiology was the introduction of the first catheter lab in 1979 that was installed in Ashab Teaching Hospital. I performed for the first time in Sudan cardiac catheterization in a child with atrial septal defect, who at a later date had device occlusion in Saudi Arabia. She was an adolescent at that time. In the early 80s, after strong lobbying, echocardiography became available. I had to lobby this a lot with Dr. Ahmad, late Dr. Ahmad, and late Dr. Abdul Halim Muhammad. Eventually, we managed to obtain an echocardiogram in the early 80s, also in Ashab Teaching Hospital. So the cath lab, in an arrangement of a cart in front of the horse, came before the echo lab was established. Anyway, by combining the setting of echocardiography and cath lab, the stage was set for establishing the major missing specialty, which is pediatric congenital cardiac surgery. So for that reason, I went ahead by creating a link with British surgeon. And that was after I had the agreement and Mr. Ahmad Abdulaziz, the senior surgeon at the time, as I said. He strongly supported my plans for inviting Mr. Christopher Lincoln from the Royal Brompton Hospital to visit Sudan to help us lay plans to start pediatric cardiac surgery. Also, Dr. Ahmad was very enthusiastic when I nominated Mr. Ibrahim Mustafa to be earmarked for UK training in 1979. And in addition,
I'm really sorry. I think we lost Prof. Abdulmunim again. I think he had problem with the internet connection in the Sudan. And welcome back, Prof. Can you hear me?
staff for training.
Prof, sorry, we can't hear you now.
We were fortunate enough to have a visit by Mr. Christopher. Hello?
Yes, Prof, I'm sorry. Yeah, we can hear you, but I think we lost your PowerPoint. Yes, that is fine now. Yeah, we can see your slide now.
It's apparently a bad net connection.
It's okay. It's okay. We'll try to.
Is it all right now?
Yes, it's okay. Yeah, just go ahead.
So we had a visit by one of the surgeons at the Royal Brompton at that time, Mr. Christopher Lincoln, who, as I said, did a lot of work on goats and lambs on bypass with Dr. Ahmed and with veterinarians. That was preparing the ground, obviously, for bypass cardiac surgery on children. Mr. Lincoln also accepted to train staff, Mr. Ibrahim Mustafa, for whom he arranged rotational training at Royal Brompton Hospital and the National Heart Institute, where Dr. Magdi Yaqub, Sir Magdi Yaqub, and Donald Ross both worked. Now the National Heart Hospital no longer exists as such. It has been dissolved and amalgamated amongst other hospitals. Christopher's visit, Dr. Ahmed also invited both Donald Ross and Magdi Yaqub, who came to Sudan. First, Dr. Donald Ross, who came twice, and then Sir Magdi Yaqub. And these people really enabled us to confidently sort of start cardiopulmonary bypass children surgery on congenital heart disease. And also in the early 80s, years of training, how it was done. So that was the first operation. Pulmonary stenosis was ASD, jointly done by Dr. Ross and Dr. Ahmed Abdulaziz. And on the same visit, another open heart surgery with the same diagnosis. And this was done by Dr. Ibrahim Mustafa and Dr. Ahmed Abdulaziz Yaqub. Can you hear me?
Yes, Prof, we can hear you, yes.
Yeah, okay.
Yeah, we are okay. We can hear you now, Prof. Yeah, sorry. Yeah,
okay. the program for congenital cardiac surgery was aborted by two sad events. In 1984, we had a visit by a cardiac surgeon from Saudi Arabia, actually, and he explicitly came to operate on children with congenital heart disease. He arrived in Khartoum in a private jet together with a full team of cardiac nurses and technicians. Months after his visit to Sudan, the country witnessed the first mass emigration of technicians and nurses to Saudi Arabia. And that dealt a big blow to the program. And few years later, in 1988, unfortunately, Dr. Ibrahim Mustafa died in a fatal fire accident at his home together with his wife. Now, if we pay a critical look at what has happened to Sudan over the past few decades, and if we take our independence date as a timeline for starting sort of chronological events, it took us only 6 years to establish the first hospital dedicated to cardiovascular disease at the Shab Hospital in 1962. So from 1956, 6 years, and we had a Shab Teaching Hospital Cardiac Center. Unfortunately, it took us almost half a century to establish new cardiac hospitals at Ahmed Qasim Cardiac Center, which was established in 1998, and the Sudan Heart Center after that in the year 2000 in Khartoum. And at a later date, the first center outside Khartoum in Madani, all of which are primarily adult centers that also offer services for children with heart disease. In all existing cardiac hospitals, care for children with heart disease is unfortunately fragmented, discontinuous, and suffers major financial constraints and lack of staff and equipment. This is the current status of our pediatric cardiac services in general, including the congenital cardiology, of course. So what have we lost over that almost half of a century in which we were lagging behind in the science of pediatric cardiac surgery and congenital cardiac surgery? We obviously suffered thousands of deaths of children with congenital heart disease. We have accumulated an ever-increasing load of patients living into adulthood with congenital heart disease and their ongoing complications. We have missed opportunities to locally train and improve the learning curves for countless numbers of medical, nursing, and technical staff in congenital cardiology surgery and interventional cardiac catheterization. We had financial losses of tens, maybe hundreds of millions of dollars to other countries that have perfected the art and business of medical tourism. Particularly in this respect, I should mention India. Other losses that are not immediately apparent to us, including the loss to economy of sort of patients who either died or who are morbid. So what are the main challenges which sort of stand ahead of us for future development? The most important thing is to have a reliable, comprehensive, sustained pediatric cardiology service But this faces huge challenges, including lack of strong government financial commitment, perhaps the most important aspect. The specialty cannot be developed by private sector. Even in wealthy countries, the input of the government, especially the financial input, is vital to the establishment and sustenance of congenital cardiology. It's an extremely expensive subspecialty. And for example, in England, the children with congenital heart disease account for less than 5% of all admissions to hospitals, but their expenses is over 25% of the total expenses for children. We also meet the formidable challenge of staff training. Training in reputable centers in Western countries is becoming extremely more difficult and more expensive. Training in regional centers is more feasible and should be adopted. The extra challenge of train and retain, what I call train and retain versus train and drain, is a very difficult challenge. The sooner you prepare staff, the sooner they leave, sort of obviously enticed by far better pay and far better living conditions. The parallel development of supporting specialties and services, because pediatric cardiology cannot stand alone by itself. It has to depend on other specialties, especially in the area of pharmacology and nursing, other medical subspecialties. They ought to be equally brought up to a level. And then increasing load of adult congenital heart disease. Now we are seeing large numbers of adults by the day who come from other centers where they were operated for congenital heart disease, but they depend on us to do their adult follow-up of the congenital heart disease. We suffer great loss and lack of database, and proper statistics on congenital heart disease. And we ought to think about standalone pediatric cardiology centers rather than being carried in the armpit of hospitals sort of designed for adults. In such situations, the budgets for children requirements tend to be depreciated. So in summary, I would say that the first congenital cardiology service in Sudan successfully took off over 4 decades ago, parented by adult cardiology and cardiac surgery. Previous experience has shown that when well-planned, comprehensive congenital cardiology service can be implemented and that it is highly needed. Future challenges that stand in the way of establishing reliable, comprehensive pediatric cardiology service include lack of government commitment, proper training, brain drain, and lack of statistics. These challenges, although formidable, but they are not unsurmountable, and they can be overcome. Thank you.
Thank you very much, Prof. Abdelmonem. This was a really fantastic talk. Just before I go to a question, Prof, okay, yeah, that's fine. Has anyone from the panel, would you like to ask Prof. Abdelmonem any question or to add anything before I go through the main point Prof. Abdelmonem he summarized, and the one question on question and answer here on the Zoom? Okay, Prof, I think the one question here, it's very good point you raised with regard, this is a lot of challenging facing the congenital pediatric surface and congenital heart disease surface and surgery in Sudan, which I think is mainly, with you summarizing lack of database, there is no standalone pediatric cardiology center, lack of pediatric intensive care, lack of suppliers, high cost of the procedures. And this is really huge challenging, to be honest with you. And then just before to go to Prof. Sulafa to comment on this point, there is a question here with regard BDA closure. I think how long we can late the BDA operations. I'm not sure, I don't think you mentioned this in your talk, but this is a question coming through the question and answer. Would you like to make any comment on this question? Or shall I leave that to Prof. Sulafa and Mr. Salah?
You are referring to PDA closure?
I think that the question, yes, one of the audience, he just asked you this question. He said, could you please ask Prof. Abdulmunaim with regard how long we can late the BDA operation or closure?
I think PDA was one of the first lesions to be treated surgically and later on by intervention. Nobody now does anything except intervention. I'll leave that to Prof. Sulafa because she apparently closes a lot of doctors in catheter lab. But I was intrigued when back in the 80s, we did with Donald Ross and Dr. Ahmed Abdulaziz and Dr. Ibrahim Mustafa, rahimahullah, we did more sort of challenging operations like ASD and PDA surgically. But then when the Ahmed Qasim Cardiac Center was inaugurated, and they brought some Chinese teams to start the work, the first thing they did was actually to close the doctors in a 16-year-old girl, which as if it was held like a big achievement. Although this is now becoming bread and butter of interventional cardiology. Unless the question is referring to PDA and the premature baby, which is another situation. Maybe Prof. Sulafa would like to have an input on this.
Yeah, excellent. Thank you, Prof. So had anyone from the panel, would you like to comment or to add anything or to ask Prof. Abdulmunaim any question?
Azim, if I may have a small comment.
Yes, alaikum salam.
Kefak, how are you doing? Just a small comment. Thank you very much, Professor Abdulmunaim. Actually, this was a nostalgic presentation for me. Nostalgic because when I was a senior registrar in general surgery, that was 1999, my thesis was on closed mitral valvotomy in Sudanese patients. So I went to an era which was governed by Dr. Ahmed Abdulaziz, Mohammed Saeed Al-Fil, and the late Dr. Ibrahim Mustafa. So most of the data was Ahmed Abdulaziz, Yaqoob's, and Ibrahim Mustafa, the great late, both of them, and Dr. Al-Fil, may Allah bless may Allah bless him. So this is quite a nostalgic talk for me because I was very closely related to Dr. Ahmed Abdulaziz for more than like a year or so doing my MD thesis. I did sort of general surgery in the districts. Then I went back to Sudan Heart Center 2005, where I was starting my subspecialty in cardiac surgery. At that time, I was very close to Dr. Sulafa and her team, and a foreign South African surgeon. His name is Ziad Karani. So this is another upsurge. So after stopping like so many years, like from 1985 till 2000, 2002, 2003, that was like 17 years. Pediatric cardiology and cardiac surgery picked up by Dr. Sulafa and Dr. Ziad at that time. Then unfortunately I left and Ziad left 2005, 2006. And then I think Murtada Ibrahim came 2007. He picked up the torch, and we came later on to operate adult, and then we start training in pediatric cardiac surgery outside in Takhasus Saudi Arabia. And then we came back in Medani to start the story all over again. So this the talk was quite nostalgic. Actually, the talk about hypothermic circulatory arrest couldn't be possible unless the researches of Bigelow in Canada. Then it was picked up by Stewart in USA, and then things become like a common rule using hypothermia in cardiac surgery. And even when the pump came in 55, 60 by Gibbon and his associates, the first to use hypothermia to its maximum is Sir, I think Barrat Boys in New Zealand. So this Barrat Boys started to go for circulatory arrest, which was adopted in some time by most of the teams operating pediatric cardiac surgery. Now we mix both of them, like hypothermia mixed with pump and circulatory arrest only in very limited cases like in arch reconstruction and other things. Thank you very much, Professor Abdul Munaim. You took me back like more than 20 years. الله يرحمه إبراهيم مصطفى. الله يرحمه أحمد عبد العزيز. Thank you very much indeed. شكرا.
Okay,
thank you,
Mr. Salah. Okay, I mean, at this point, I think I would like to close this session and just to say thank you very much, Prof. Abdul Munaim. That's an excellent point you made regarding the historical perspective.